Hi, this is Michael Altos. We are continuing our discussion of blood, and this is recording part 10. First, let's take a moment and talk about the allowable blood loss calculation. In order to calculate allowable blood loss, we first need to determine our transfusion threshold, and we also need to determine our patient's average blood volume. We can calculate that based on body weight, and here's a chart that shows average blood volume for patients all the way from premature babies all the way through adult men and women. The allowable blood loss looks at the patient's estimated blood volume, the difference between the initial or starting hematocrit and the final hematocrit, which is your transfusion threshold. And using that, we can calculate allowable blood loss. You may have instructors who expect you to calculate this information. There are several ways we can try to conserve blood and prevent transfusion. The first is a preoperative autologous donation or a directed donation. This is collection of blood in the days or weeks prior to surgery and is most commonly seen in high blood loss surgeries like orthopedic, cardiac, or prostate surgery. We can collect up to 450 milliliters every week until 72 hours before surgery. Of course, the donor has to have a significant hematocrit to begin. Usually we expect the donor's hemoglobin to be greater than 11 grams per deciliter. This could actually be done far enough in advance and the blood could be frozen. It does reduce exposure to antibodies from other donors, and so this may be useful for our allo-immunized patients. It's expensive, and it doesn't prevent the errors and other risks associated with stored blood. Patients may be given EPO in order to increase red cell production, and that helps, but it is expensive and it requires multiple injections. EPO may also increase the risk of thromboembolic events. Some give these patients vitamin B12 or folate and iron if they are deficient. Some patients are contraindicated for preoperative donation. That includes young patients, those who have an infection or bacteremia, aortic stenosis, recent coronary or cerebrovascular disease, congenital heart disease, or uncontrolled hypertension. ANH, or acute normovolemic hemodilution. The idea here is that in the operating room, we withdraw blood until their hematocrit is 25 to 30%. In order to do this, we replace the blood with fluid in order to maintain euvolemia. The blood is actually stored right there in the operating room at room temperature for up to 6 hours. This way, when the patient bleeds intraoperatively, they're bleeding a low hematocrit blood, and then when they require blood cells, we can transfuse back that whole blood that we collected from the patient. There is a modest benefit here and may reduce allogenic transfusion by 1 to 2 units, but it isn't routinely recommended. Again, useful for patients who have alloimmunization or who can't accept allogenic blood or won't accept it, but the same contraindications as before will still apply. Cell saver, which is perioperative blood salvage, involves suctioning the blood from the surgical field, collecting it with heparin or citrate to prevent coagulation, filtering it, centrifuging it, and washing it. Now, this creates a dilutional coagulopathy because all the coagulation factors are removed. But in the end, we end up with salvaged blood spun down with a hematocrit of 60 to 70%. Historically, we didn't do cell saver in patients who had infection, malignancy, bowel perforation, or amniotic fluid. We were concerned that fat or microaggregates or air could get into this product that we're transfusing back into the patient. And of course, free hemoglobin or heparin, bacteria, or debris could all be harmful. Modern systems really remove pretty much all of that stuff, except maybe bacteria, and that can be reduced with a filter. And so nowadays, there's a lot of data to show that cell saver may be used in just about any patients. Although if there's a malignancy in the site of the surgery, it may be appropriate to filter or irradiate the blood before giving it back to the patient. And if there's an overwhelming concentration of cancer cells in the shed blood, it may be wise to avoid cell saver completely. The benefit for this process has been shown in major surgeries like cardiac, orthopedic, or spine surgery, as well as patients who can't receive allogenic blood. There's also an idea called postoperative blood salvage, And this involves chest tubes or drains being collected, that blood being immediately reinfused, sometimes without even being washed. And there are different questions about whether this is appropriate, whether it may increase coagulopathy or infuse inflammatory mediators back into the patient. Unfortunately, to this day, we don't have any good, reliable artificial bloods, that is, a hemoglobin-based oxygen-carrying solution. There have been many attempts, but all of them have had severe complications like renal failure or this free hemoglobin interfering with assays and causing vasoconstriction. We know that there are patients who will not accept blood under any circumstances for religious purposes. In these patients, we have to have a discussion with them, determine which products are and are not acceptable to them, and consider various components, concentrates, albumin. We can ask them what their opinion is about removing blood and returning it back to them, like ECMO, coronary, cardiopulmonary bypass, acute normovolumic hemodilution, or cell saver. But most importantly, have that detailed conversation with them and certainly document the results of that conversation. That's it for this section. Please let me know if you have any questions about the material.